Okay, good evening, everyone. Today we are going to discuss about one topic from infection control, that is care bundles. Okay, very important topic. Almost 3 to 4 questions will come from this chapter for your exam point of view. It's an easy chapter. I'm sure already 80% you all already know about it. Okay, so if you pay attention, that's sufficient for you to appear for exam for this chapter. So what are care bundles? So care bundles are, good evening to all of you. Today, big number participation. Ashna, Ashvita, Bindu Varghese, Cherian, Binya, Blessy, Deepti, Aliza, Godwin, Aileen, Jennifer, Kajal, Pushpavali, Purnima, Omkar, Pauline, Ravi, Sara, Sarita, Shonima, Smita, Somali, Sujata, Sunita, Supriya, everybody, good evening. Okay. Those whose names I have not taken, probably you have not labeled it. You have to label your name, na? iPhone and this and all, I won't understand. Okay. So, care bundles are certain bundles or certain protocols that are placed in your organization, in your SOP, in such a manner that it is compulsory, it is mandatory. You follow that to avoid such kind of infections. So, care bundles are specifically for your healthcare associated infections, okay, which are there prevalent in the hospitals. In certain hospitals, it's at a larger number. Some hospitals, it's not much. Some hospitals, it's not shown. It's different for different hospitals, okay. So these are your care bundles. Now, what are HAIs? Healthcare associated infections, or HAI, are infections that patients acquire while receiving treatment for medical or surgical conditions in a healthcare setting. This infection can result from various factors, including use of medical devices, invasive procedures, antibiotic use, lapse in infection control practices. Any of these things can cause an hospital-acquired infection. Some of the indicators of HAI, if I ask, I'm sure all of you will answer. It's fever, WBC increased, general weakness, increased heart rate, and if it's a UTI, positive culture for urine. If it's an respiratory tag, that will be positive. If it's bloodstream, blood positive. So it's like that. Okay, so positive culture report. These are some of the general indicators of hospital-acquired infections. Now, so we need to consider 4 important things. And which are they? One is VAP, then is COTI, CLABSI, and SSI. VAP is ventilator-associated pneumonia bundle. COTI is catheter-associated urinary tract infection. Third one is CLABSI, central line-associated bloodstream infections. And fourth one is surgical site infections. Now, I'm sure all of you have understood this. So these 4 healthcare associated infections you have to know in detail. Now, let's look at VAP. What is a VAP bundle? So every infection associated with bundle, it's called VAP bundle. So VAP bundle, COTI bundle, SSI bundle, and CLABSI bundle. Like that, there are many other bundles. HAPU bundle. HAPU bundle is for pressure ulcer. Any other bundles that you all know of other than VAP bundle, COTI bundle, SSI bundle, and CLABSI bundle? Any other? HAPU bundle is for pressure ulcer. Any other bundles that you know of? It's good, when you have a group and some new bundles come in, it's an information for everybody who's attending the class. Any other bundle that anybody knows other than these? I think these are the most common ones which are practiced in the hospitals. From other countries, if anybody has any other bundle, you can discuss. IV care bundle, IV site care bundle. Okay, Good. So some hospitals, they just prefer to limit it to just CLAPSI bundle. And CLAPSI will come in central line, and IV site will be like specific to IV. PVSM, what is full form of PVSM? Sarah? Peripheral vascular access. Yes, yes. So that's what the IV site bundle. There are few hospitals who will also have the IV site care bundle. Very good. That's nice. So first we move on to skincare bundle for bed sore. Yes, yes. So that is a HAPO bundle. Pressure ulcers, yes. And sometimes fall prevention, like they use it as a fall prevention program, but there are some hospitals which you have a set of it's called as a bundle. Fall prevention bundle is also there. So yes, this word bundle is loved by hospitals, audit committee, JCI, NABH, like that. Okay, so let's go to the first one, that is VAP bundle. They are a set of evidence-based practice aimed at preventing VAP in patients who are mechanically ventilated. Okay, so if you have a patient with ventilator and if you implement this bundle, it's better for the patient outcome and it will reduce his chances of getting VAP. Now, so how do you find out whether the person has VAP? One is your cultures have to be positive, fever, then new progressive pulmonary infiltrates, decrease oxygen levels in blood, hypoxemia, and sputum culture has to be positive. This is confirmatory for VAP. Everybody knows fever is 100%. Leukocytosis or leukopenia, increase count or decrease, extremely decreased count. Then new infiltrates in the chest X-ray, hypoxemia, and positive sputum culture. Now, what are some of the VAP bundle parameters? See, if you search on net, no, you will get a lot of points. You will get, some places will have 5 points, some will have 6 points, some will have 8 points, some will have 10 points. The question is not how many you know. The question is how many are you correctly following it in your hospital. So some of you are already working as educators, infection control members, quality personnel, ICU in charge, OT in charge, boards in charge, HDU in charges. So make sure whatever you do, it is applied correctly and people do follow it. Okay. Now, head of bed elevation, HOB elevation. So, except for people with femoral sheath or somebody who is who's propped up is contraindicated, you should at least have head of bed elevation. So, how does HOB elevation help? It helps in removing the secretions. Diaphragmatic movements are good. Okay. The patient is able to expectorate properly. Therefore, there won't be pooling of secretions. Therefore, the chances of VAP is minimized. Okay. Also, his cough reflexes are improved. Imagine when you're lying straight on the bed and trying to cough. Your sputum will still remain inside the lungs. Then, daily sedation hold, or it's called a sedation vacation. Whenever I go for training to other hospitals, some people are not aware of what is sedation vacation. ICU people, sometimes they are aware of it, but other places, the ones who are working in the wards and all. So what is a sedation holiday or a sedation vacation or a sedation hold? When the patient is on a ventilator and he's on sedation, the intensivist, the protocol will be that you have to stop the sedation for some time to check whether the patient is tolerating to the breathing and check. So switch off the sedation that's going on for the patient and check his response. Yes, for few hours. And check whether there's a ventilatory fight, whether the patient is able to tolerate well, look at the respiratory rate, heart rate, and then accordingly you can wean the patient out of the ventilator. But if you don't Give a sedation vacation, the patient is going to be immune to that ventilator, addicted to it, and he'll be dependent on the ventilator. Okay, so to release him slowly, to wean him out, basically. That is sedation hold. So that will help you. The more he's on a ventilator, the higher the chances for VAC. The faster he is out of the ventilator, the less the chances. That's why we say, no, remove all the lines as soon as possible. Next is 12-hourly oral care. Here I mentioned 12-hourly. That is the least that you can do. But ideally, it is 4-hourly. Okay, 4-hourly oral care is mandatory. You can divide the patients in the ICU as high, acute, like somebody who is just a patient who has already brushed his teeth properly. Okay, we don't need. But somebody who's on a ventilator will need 4-hourly. Okay, sometimes the in the interior and all, nobody does it for 4-hourly. But if you are in a hospital, you are in a private organization, mandatory, it has to be 4-hourly oral care with chlorhexidine solution. Okay. Then subglottic suctioning. So you before we used to have the open suctioning, but the problem with open suctioning is you cannot maintain asepsis. You will touch your sterile gloves here, there, and therefore the suctioning procedure itself is unsterile. You won't be able to maintain sterility. But when you have a closed suction, what happens? Subglottic is you suction below the glottis. At the same time, when you have a closed suction, okay, SteriCath. I'm sure all of you are aware of the SteriCath. 100% there is no break in the sterility, and therefore there's least chances of infection. And how frequently do you change the SteriCath? Can you all tell me? Those who are working in the ICUs, how frequently do you change the SteriCath of the patient, the closed suctioning system, the tube, suction tube? So how that SteriCath has to be changed how many hours? Not 7 days into. You all are using it for 7 days? Not that. Not 3 hours. 48 hours is the right answer actually. Sometimes some hospitals use it daily. Yes. So if there are not much secretions, you can use it for 2 days. But otherwise, it's on a daily basis. Jennifer is from which hospital? Daily it is 24 hours. Okay. 60% of the hospitals change it daily. So that also helps in prevention of VAP. Okay, that is called as the SteriCath. Then 4-hourly cuff pressure check. So why do you check the cuff pressure of the ET tube? You have the cuff, right? Yeah. So Jennifer is from Qatar Hospital. That's why. Yeah. Every shift you have to check the cuff pressure. Yeah. It can get deflated. It can, again, accidental removal can be there or pooling of secretion. So always make sure you check the cuff pressure when you come on shift. Then stress ulcer prophylaxis. What is that? GI prophylaxis, gastrointestinal prophylaxis, or peptic ulcer prophylaxis, or stress ulcer prophylaxis. There, you are going to give the patient prophylactically pantoprazole, all your prolols or H2 receptor antagonist, that is ranitidine, or any of the antacids. Okay. Yes. So that is it. There's one more. GI prophylaxis is one, and one is DVT prophylaxis. Deep vein thrombosis prophylaxis. DVT prophylaxis, how? Now, how is this stress ulcer or this related to your lung? This is in the stomach. Lung is VAP. How is it related? The relation is, so when the patient is lying on the bed with the ventilator on and you're continuously feeding him, RT feeds and all, there's a high chance that he's going to be feeling bloated, feeling of fullness, acidity, sometimes aspiration, sometimes bleeding. All this can happen. So to avoid all these things, you're giving prophylactically antacids. Yeah, regurgitation, all these things. Okay. In the same way, we have DVT prophylaxis. For that, you're using DVT stockings for the patients, SCD pumps, sequential compression devices. Yes, stockings, compression devices, and also low molecular weight heparin. Yes, insulin, heparins, um, Clexane, all those things. Okay, all will be low molecular weight, so that there is no stagnation of blood pooling, no clots formed, and there is no chances of pulmonary emboli. Pulmonary emboli is a life-threatening complication. The patient can even die. So that's why you're supposed to prophylactically treat the DVT also. So WAP bundle includes all these things. Oral hygiene every 4 hourly to 6 hourly, DVT prophylaxis, GI prophylaxis, head elevation 30 to 45, sedation, vacation. Also, anything that is deals with your pulmonary hygiene, lung hygiene. So your chest physiotherapy, okay, your spirometry and deep breathing exercises, coughing exercises, suctioning, all these are there in your WAP bundle. Okay. When you do postural drainage, especially the therapists do it very well. When you do postural drainage, the secretions are mobilized, and therefore it's easy for the patient to cough it out. Okay, expectorate it out, nebulizations, all these things will help in maintaining hygiene of the lungs. All right, I'm sure you all have all understood WAP bundle. Now let's move on to COTI. COTI is catheter-associated urinary tract infection. So what's a COTI? It's an infection involving any part of the urinary system. It can be urethra, bladder, ureters, kidney that occur in a patient who has a urinary catheter in place or has had one recently. Okay. So as you can see the urine bag here, the first thing when you see it, it has to be like this. You can't have your urine bag full and it's on the patient. Okay. So COTI. So you understood. So again, fever, urine culture positive, leukocytosis, leukopenia, all these are chances or confirmatory to find out whether the patient is having COTI. Catheter-associated urinary tract infection, fever, also suprapubic pain. These are some of the symptoms. Then costovertebral angle tenderness. As you can see in the picture, there's a tenderness. Urinary symptoms, increasing frequency, urgency, dysuria. All these are some of the symptoms. And positive urine culture, growth of the bacteria. Now, what are some of the causes of COTI? COTIs typically occur when bacteria or other pathogens enter the urinary tract through the catheter. The risk increases with the duration the catheter remains in place. Factors that contribute to the COTI include poor aseptic techniques, contaminated equipments, long duration of catheterization. So that all of you know, if you have Foley's catheter, then you'll convert it into a silicone catheter so that you can at least extend it by 21 days. Now, what are some of the parameters in COTI bundle? So the mnemonic is no COTI. N stands for need for catheter assistance. Only if there's a requirement for catheterization, you have to put. You know, there are people who are on cesarean section. LSCS is done. After that, after 1 day, the catheter is removed. Because the patient is lazy, she says, I want to keep this catheter for 2 more days so that I can be on bed. And what is the ideal scenario? You are supposed to get out of the bed and start walking even if there is some pain. In abroad and all, they motivate the LSCS patients to walk on the second day itself. In India, it's a little slower. So need. If there's no need, remove the catheter as soon as possible. Then always obtain consent of a patient education. Competency. Only competent people should do the catheterization. Otherwise, there'll be bleeding and all those things. And also asepsis to be maintained. Unobstructed. No king should be there. Catheter removal. Early removal of the line and tubing. And collect urine specimen only when indicated. That is infections. When there is a requirement. Otherwise, don't collect. Now, let's move on to... Yeah, same day evening patient is mobilized to chair. Exactly. So once you're mobilized to chair means you are able to walk and go through the washroom. Right. So what are some of the 40 parameters? First thing, follow strict asepsis. Very, very important. That means hand hygiene. You have to use your PPE, personal protective equipment. Next thing is give catheter care, and all your things you have to maintain while insertion, during the catheter in place, and even at removal. Every time you have to have asepsis. Second thing, make sure catheter care is given with betadine or with soap and water or with your wipes. Whatever is your hospital protocol, follow that and do it 8 hourly. Okay. So there are some hospitals which prefer to give betadine even now. CDC guidelines say soap and water is sufficient. Okay. No need of betadine. Betadine causes dryness. Some cardiac related hospitals will say, I want betadine only. I'm not worried about the dryness. For me, the more concern is infection. So I will load with betadine. So that is up to management, but this is the requirement. Okay. Next, always secure the catheter on the thigh of the patient so that there is no traction or a pull that is created, which can cause bleeding again and again infection. Assess the urine bag to check whether it's color change, pus, and all those stuff. Okay. Then urine bag should be emptied when 3/4 full. Then when do you change the Foley's catheter? How frequently you should change a catheter? Anyone? Is it still 14 days? When the hospital is not allowed for soap and water, is the wipes that you use, na? The sterile wipes. 14 days, na? Okay, 14 days. And Leelavati is saying 7 days. So different hospitals have different protocols. 7 days, 14 days, silicone catheter, 21 days. Correct. So you see, in one only country, there are different hospitals with different protocols, depending on the type of patients that come in. Okay. So follow your hospital protocol. 7 days, 14 days, and silicone catheter 21 to 28 days. These are the, on an average, this is the number. Okay. Yeah. So then that is it then. When the patient is being taken for some other procedure, yes, keep the bag at the below the waistline so that there is no backflow. Tell me one thing, urine is sterile or unsterile? Let me see who is smart. Urine is sterile or unsterile? Some are saying sterile, some are saying unsterile. Very interesting. See, Snigda is right. Sterile when inside the body. Correct. All those who are saying unsterile, you all are looking at the bag, urine bag, and saying unsterile. So urine is sterile in the bladder. And once it's out of the bladder, it is unsterile then. Okay. So this unsterile urine, again backflow, will cause infection. That is why you have to keep the urine bag below the waistline. If you keep it up, again what is come outside is again going inside. Backflow. Okay. I hope you all are clear. Then, when you are taking the patient for any MRI, CT scan procedure, yes, close drainage system, and also still avoid that this thing. Clamp the catheter. Okay. Now, in certain hospitals, I've seen they will clamp the catheter, take the patient, and then while coming back, then they forget because the catheter is hidden. The clamp is hidden. So remember to declamp. Otherwise, best is to empty the bag completely and take the patient. That is one more thing. Then follow the strict aseptic this. Remove the catheter when not required, and also while removal, maintain asepsis. So these are urine and black garbage bag. Why they put diaper with urine in black garbage bag? Diaper urine will be in yellow bag, if I'm not wrong, not in black. Are because the diaper and all, who's handling? Housekeeping, they only don't know half the things. See, I got an answer. Yellow bag is the right answer. Because diaper is not handled mostly by nurses. It is that mama maushi that handles. And then what is followed, they just follow it. So if your hospital is following that, you should ask them. Okay, it's in abroad, na? Yeah. So just check, like, because yellow bag is for all your infected gauze pieces, all those things. So there'll be a protocol. It's fine. It's fine because see, there are people who the diaper. It's a question you can ask your microbiologist how it is. But in India, it is yellow bag. Because Sarah, first you were in India, no, that is why you are having the confusion. So your confusion is right. Yes. So yeah, you can ask that. And you can message me separately. So I'll also know what's the reason. Okay. So that is with that. So that is with the Cotti bundle. So we've covered Cotti bundle now, okay? And follow strict asepsis. Oh, great. Congratulations, Sarah. Just ask because like in India, we don't have it as black bag for diaper with urine. It's yellow. This is good, like, when there's a discussion from other countries, it actually helps. And it really helps. So please get back to me this black bag, maybe. And what else is there in the black bag, Sarah? So what category of waste comes in the black bag? Sarah, I have unmuted you. You can speak.
Wait.
Yeah, Sarah, tell.
You see, I am working here, infection control link nurse. Okay.
Yes,
Many
yes.
in India also I have many more near to 23 years I have experience in India also 10 years I work in government. That time also
Very
I
good.
work as an infection in infection control only.
ICM. Correct.
But that time I have this yellow bean, red bean, sharp different, and this black. Okay, in black we
Yes.
are using almost for the domestic. Yellow, anything, whatever fluids come from patient's body, it will be thrown in the yellow bin like that.
Correct.
I learned from infection control as well in our policy also.
Correct.
But when I came here, when I been doing as a selling nurse here, that time I saw that they are putting this all this what is a diaper with urine, diaper with stool, everything in the what is that
Black bag.
in a black bag.
And
Then
what
I
else is
asked
put in the
them,
black bag? What else is put in the black bag?
other domestic also there, other domestic also there. But even though they with domestic they are throwing that, and then I asked them that what is this policy, and according to they are telling that according to Hamad policy is like that
Oh,
they told me like that. Then what they
okay,
answer
okay.
them, if urine is not infected, how
Huh.
we cannot whatever be fluids we are going, that is a toxic, that is a toxins already.
Matlab, as per the standard practices, we will consider it as infected.
Yeah. Then also they throw this. Then what they clear me, that
Hmm.
in our now I am working in long term care patients. That long
Yeah,
term care patients, this they are any not patient. They are long term any same like a human beings only. As we
correct.
pass urine, same they are passing urine. That is
Yeah,
the
yeah,
correct
yeah. I
method, I
totally
guess.
agree. Totally agree.
Uh,
Like, suppose we are at home and we are taking care of our babies, we would
yes.
just throw the thing in the dustbin. Yes.
Yeah. Then they said me like that if patient is contact isolation and if patient have
Hmm.
MDRO, otherwise any pseudomonas, otherwise
Any disease condition or
any
a
disease
proved
condition,
infection, then you use the
then
yellow bag.
Yeah, they told me like that only. They said
Yeah, so
they give me
that
answers.
absolutely okay. That's fine. That's fine. That's
But
fine.
still I am
Okay.
confusion because they are keeping patient in hospitals for what?
Because
They
they are
cannot.
admitted because some disease condition is there.
Because now patient is not MDRO, but he has before MDRO. He is known case of the CRE. He is known case
Correct.
of the Pseudomonas. That means the organism will not go. Some patients are
And
MRC positive.
actually by whether we are not disrespecting the patient by throwing his pamper or her pamper into the yellow bag or black bag, but then it's better to follow what the hospital states,
That is
there.
so
Yeah.
I was if they ask me, I always fighting with them for that one. But really, because I want to go, I want to know the what's the truth and what is the scientific. We are doing evidence based nursing now, so we
Correct,
want
correct.
that
And it's
evidence.
so important. Yes, yes.
So that I
Yeah,
always
so
getting problems with them.
confused.
That this is not like this is like this. Always. So I want just now you told me no, regarding that
Yeah,
one.
because
So that
urine is
only I want to
sterile
ask.
inside the body. Once that
Ah.
urine comes out, that is why you remembered this point, right?
Yeah. For that, I
Correct,
want a
correct.
clear answer from you. And that one,
Yeah, so
there is a
see,
one question.
your concept is absolutely clear because when they say कि it's a normal patient, you are saying उसको previous था ना, so sometimes it can happen कि he can get again. Anybody can be
Yeah,
infected, correct?
yeah.
So even
So
you are
for
right
me,
from your part.
from my side, I said them, please follow the globally whatever WHO accepting. You follow that one.
Yeah,
Don't follow your
WHO and the
hospital
CDC
policy.
guidelines.
The CDC guidelines only we have to follow. I
Correct,
talk like
correct.
that to them. I don't know I am
Good,
correct
good.
or not correct, but I am
You're
fighting for
you're
that.
you are an assertive nurse. So go ahead with that. And it's good to take inputs like that. It's very good.
Yeah,
Thanks,
thank you.
Sarah, for
Thank
your
you.
valuable input.
Yeah, thank you,
Okay.
thank you.
Yeah. So we continue with that this thing. Then we have surgical site infections. No, we'll do surgical site in the next class. Surgical and this. We did till this thing, na? Corti and VAP. So what I want you all to do is all of you open your infection control textbooks. Those who are doing infection control course, take your textbooks and start reading your bundles of VAP and Corti. At the same time, start reading the whole book. At least read it 3 to 4 times. That is sufficient for your exam. Exams are going to be held in the first week of September. Okay. So all of you start reading your books and other information will be given to you gradually about the exact dates and all. No need to message. They will give you. You will get message from either Dr. Pavan Mittal sir or from Anishma ma'am or from me or Pallavi ma'am or you will get it from whoever is your mentor. Okay. So that's there. And this time paper is also very easy. So tomorrow, as usual, 3 o'clock will be Six Sigma lecture, 4 o'clock will be quality management, and 5 o'clock will be infection control. Okay, and read all your textbooks. Start reading, start preparing because now it's already August 16. There's hardly 15 days remaining for the exams. Those who have appeared ready, those who are for this time exam. Some people are not for now; they have to appear for exam in February. But those who are for now, start reading your books. Okay. Anybody has any doubt till now? Anyone has any doubt? Okay, great. So no doubts. Then see you for the next session. Till then, have a happy weekend. Take care. Bye, everybody.